Endodontic sealers are used to fill the space between the obturating material, or gutta perca, and the canal wall. We want to ensure that there are no gaps left which bacteria can multiply in, and that there is a good coronal and apical seal. The ideal properties of a root canal sealer were described by Gutman in 1978. They included that a sealer should, firstly, be tacky when mixed and set to provide an excellent seal between the canal walls and the core obturating material, be dimensionally stable, have a sufficient working time, be insoluble to tissue fluid, have adequate adhesion to the root canal walls, be biocompatible and not irritate the periapical tissues, be bactericidal and at least bacteriostatic, be radiopaque, should not shrink on setting, should not stain tooth tissue, and should be really easily removed if necessary. You've all heard about sealer puffs, so during heat canal obturation methods, you can often get a puff of sealer beyond the apex. This occurs most often when used with a heated technique. The GP is to length, but the heated downpack pushes some sealer beyond the apex. Puffing became popular because it shows good length control with your GP point, but that the canal is also patent beyond this point. But ideally, we should restrict filling materials to within the canal space. It is important we use sealers that are biocompatible and do not cause apical inflammation. It is also nicer for the clinician if the extruded sealer resorbs with time. However, evidence shows that treatment outcome is not affected by sealer extrusion or the type of sealer extruded. It can be confusing knowing which sealer to pick, so let's go through a few on the market. So firstly, zinc oxide eugenol based sealers. These are probably the most widely used sealers and have been used for many years with success. They are antibacterial and biocompatible, and if they are extruded, they do tend to resorb. However, they do cause staining if not removed from the coronal part of the tooth post-treatment. Examples include Tubaseal and pulp canal sealer. If you're using a heated technique, make sure you buy the extended working time or EWT version of this sealer because heat causes the regular sealer to set too fast. Next, let's talk about resin-based sealers. Resin sealers, such as AH+, are antibacterial and have good adhesion to the root canal walls. They also have good flow to help fill voids, which means they have a higher tendency to fit lateral canal spaces. They're also very radiopaque, so your root canal filling will look nice and dense and pretty when using it. The negative is that, as with all resins, they exhibit a slight shrinkage on setting, and if there is any sealer extrusion, it's less likely to resorb. Next is calcium hydroxide-based sealers. The idea behind this sealer was to utilise the antibacterial activity of calcium hydroxide. Unfortunately, the sealer doesn't display much of this once it's fully set. It can also resorb over time. An example includes Sealer-Pex. Following this, we've got GIC-based sealers. These became popular some time back because of the dentine bonding properties. However, they have no antibacterial properties and are difficult to remove during retreatments, so they've lost a lot of popularity. An example includes Keitac Endo. For all the sealers we've talked about so far, we need to consider the sealer as the weakest part of the obturation, and ideally we want the majority of the canal to be obturated with GP with a very thin coating of sealer around it. However, this last sealer we're going to talk about was made for a single cone obturation technique where the sealer forms a more significant part of the filling, and they are bioceramic sealers. These are the latest sealers that have been launched on the market. They contain calcium silicate or calcium phosphate as their main components. These sealers are hydrophilic in nature and utilise moisture in dentinal tubules to initiate their setting reaction. They are antimicrobial, biocompatible, don't shrink and produce an excellent seal by bonding to dentine. This makes them particularly useful if the apex is slightly wider, where you potentially have a more biocompatible and better seal. The main downside is they make retreatment very difficult. If you haven't managed to get to working length with your GP cone, then you will tend to block the canal apical to this, which prevents retreatment. They also don't resorb if extruded beyond the apex, and they are the most expensive. Currently, most bioceramic sealers on the market can't be used with a heated technique because it ruins the property of the sealer, and they should only be used with a single cone technique. I prefer using a warm vertical technique, so would need to use a bioceramic sealer like Endosequence BC or Total Fill BC high flow, which can be heated to 100 degrees without damaging its properties. They come in a syringe and can be placed directly into the root canal system. Choosing a sealer is very much up to personal preference because no sealer we have discussed has all the ideal properties. I personally use a variety of sealers depending on the case. My go-to sealer is Pulp Canal Sealer by Kerr. It comes in a powder liquid form, so I can mix it to the consistency I require. So it's thicker for cases that the apex lies close to the sinus or the ID nerve, or more runny when I need it. I find that patients don't have much post-operative discomfort even if I get a sealer puff, and any extruded sealer resorbs with time. Sometimes I use AH Plus if I have more complex anatomy, for example if there is a 2-1-2 anatomy, and I want the sealer to flow more. I use bioceramic sealers in cases where the apical gauge of the canal is quite wide, so for example 45 to 60 gauge. For these cases, I feel a bioceramic sealer is better because it's very biocompatible and provides a better apical seal than others on the market.